I just got it wrong a moment ago. It's 3 years, not 2. It was 2007. Sign of old age here. I got it wrong. Memory going. Anyway, my pancreas is working, not my memory. And that, I suppose, is due to surgery that I experienced in this place and with the team to which you belong. A jolly good team, if I may be so bold as to say. And it's surgical developments, I think, that you're going to be talking to us about tonight. And I think I'm going to say no more, except we're looking forward very much to hearing what you have to say. So,
David, thanks very much for your very kind introduction for the team as well as for myself. And thank you for pointing out my increasing age as well. I also didn't realize it was 3 years since I last did this. As Pauline was pointing out, I think I've been part of this team which have looked after you at some point or the other for a little over 10 years now at various different levels. For those of you who haven't met me before, I have just finished my training and I'm a senior fellow now waiting for a consultant job to appear either here or somewhere else. I may or may not be around for very long, but it depends on what happens. What I felt I would do today, as we spoke before, is that surgical developments. Let me start with a bit of a disappointing news, is that there isn't a lot of surgical development as far as treatment of chronic pancreatitis or acute pancreatitis is concerned. However, there is a bit of a change in the way we treat patients, and I think what I wanted to highlight today is more on when not to operate on patients rather than when to operate on patients, and what we base that decision on, and how we have changed the way we operated on patients with either acute or chronic pancreatitis over the last few years, how we have changed the way we manage patients. Now, what I'll try to do is, the plan for this evening will be, is it about 40 minutes? Is that right, David?
Fine.
Not 40 minutes. We'll try to keep it brief. And we'll talk about pancreatitis, and I think the last time when I did it was based more on chronic pancreatitis and pancreatic diabetes that we spoke about.
Yes.
And I think the last few talks have kind of been more towards chronic pancreatitis. So I tried to kind of mix it up a bit between acute and chronic pancreatitis and the surgical management of these two. So we'll talk about pancreatitis in general. We'll talk a bit about the types of pancreatitis, and which I think you have all know about this. It has been in various different meetings, it has been highlighted why acute and chronic pancreatitis are two completely different diseases. We'll talk about the indication for surgical intervention, when we should offer surgery and why. And as I was telling you before, the timing of surgical intervention, which is the most important thing as far as we surgeons are concerned, and the problems of surgery. And then we will probably take any questions. And this is obviously a very informal talk, so as and when you feel like asking anything, just stop me and ask questions. And I have kind of deliberately left some statements vague so that you can ask me some questions. So whenever there is any burning issue, something you want to clarify, just ask questions. So starting at a very sort of simple level, we all know this, anything which has got an itis at the end is an inflammation. So when we talk about pancreatitis, it's pancreatic inflammation that we're talking about. And for all practical purposes, it has got two broad divisions which determines how the person is going to behave. And not only that, it is also kind of indicated how the inflammation developed. So if you look at anybody who has got pancreatic inflammation, there are two basic things that happens. Either it's a temporary inflammation or a temporary damage, which is a short-term problem, and usually the damage is reversible. And this kind of is the group which we describe as acute pancreatitis. And the other group is obviously those who have got a more prolonged period of illness with more prolonged, permanent, irreversible damage to pancreas, with scarring of the pancreatic tissue, which are the chronic pancreatitis. And I have deliberately not done any connection between the two because majority of the time there isn't any connection between the two. These two are completely different diseases, although both leads to pancreatic inflammation. Now, so by definition, as I have just now mentioned, acute pancreatitis is an acute inflammation of pancreas. It's usually self-limiting, not always, usually self-limiting, and it is potentially fully reversible, but it depends on the degree of damage to the pancreas. But as I said, it is potentially fully reversible. So somebody who has got acute pancreatitis can have a completely normal pancreas when the person recovers. And it rarely causes serious illness, including multi-organ failure. But when it does cause multi-organ failure, it is a very serious illness. Whereas chronic pancreatitis is a chronic inflammation, so it's a progressive pancreatic damage that we see in chronic pancreatitis. There is loss of pancreatic tissue and fibrosis always associated with chronic pancreatitis, and it causes deficiency of both the functions of the pancreas, that is, production of enzymes for digesting food, which is usually referred to as the exocrine function of the pancreas, and the endocrine function is the function of producing hormones like insulin, like glucagon. And both gets affected in chronic pancreatitis in varying degrees. Just a few words about causes of acute pancreatitis. We probably all know this, that alcohol is perhaps the commonest cause of acute pancreatitis in this part of the world, and the other common cause is gallstone. Now, if you take these two together, about 70% of all patients with acute pancreatitis will have either one or the other. It's quite often we get patients who have got gallstones and have pancreatitis due to alcohol, and it's very difficult to then figure out what was the cause of it. It doesn't really matter. The end result of the inflammation doesn't get changed by what is the cause of the inflammation in the first place. But these two contributes to vast majority of the patients that we see here with acute pancreatitis. There is another group which is quite important, is the drug-induced acute pancreatitis. I've just mentioned a few, immunosuppressant drugs, those who have had previous transplants and things like that, or those who are getting immunosuppressant drugs for the particular disease like rheumatoid arthritis. It's quite a common cause of drug-induced pancreatitis. Steroids and statins have been referred to as one of the causes of acute pancreatitis. It's quite important because lots of people are on statin. And again, when they get acute pancreatitis and we can't find the cause, we think of this as a possible cause, although it cannot be proved though. Now, there are lots of other drugs which may cause it, and I haven't mentioned that here. It is always very difficult to make a cause and effect relationship between a particular drug and acute pancreatitis. And we must always accept that about 10% of acute pancreatitis will never find a cause. And if we can't find a cause, that does not mean that we can't treat it, because the treatment of acute pancreatitis almost never has anything to do with the cause as far as the treatment of the acute phase is concerned. But what is very important is we try to find the cause because we try to prevent further attacks. Another very common cause we have found, biochemical problem, is those who have got high cholesterol level. Now, these are over and above rare causes of acute pancreatitis, but we need to think about them when we cannot find either alcohol-induced or gallstones as the cause of a particular patient. Just to show you that there are similar causes, so alcohol is again the commonest cause of chronic pancreatitis, but the process of inflammation, the way it causes these two are completely different, in the sense that it develops after excessive alcohol consumption over a certain period of time. So it's not related to one bout of binge drinking and then having a bout of pain. That's different. That's acute pancreatitis. Whereas chronic pancreatitis, it causes chronic scarring of the pancreas over a period of several years. 10 years is a bit of an arbitrary figure. It varies from person to person. And again, in this part of the world, about 70% of the chronic pancreatitis that we see is related to alcohol. Lots of patients ask us that can gallstone cause chronic pancreatitis? The answer to that in general is no. Gallstone does cause acute pancreatitis. However, In about 25% of the patients with chronic pancreatitis, there is gallstones as well. And it is generally believed that that's not the cause, it's just an association. But lots of patients do ask us about it, and it is important to know. In the chronic pancreatitis group, it is probably a slightly larger percentage, about 20%, in whom we never find an obvious cause for it. And also, drug-induced pancreatitis is, there has never been a very strong association between chronic pancreatitis and specific drugs. There are lots of other causes of pancreatitis. Hereditary pancreatitis, it's a genetic disorder. Symptom usually appears early, so younger patients, and eventually you will have quite a significant damage of both exocrine and endocrine function, and usually there is association of a very strong family history. There are lots of other causes like autoimmune diseases, congenital causes like abnormalities of pancreatic anatomy that can cause chronic pancreatitis. Diseases like cystic fibrosis can cause chronic pancreatitis. So this is just to give you a little bit of an idea. Now, the important thing about this is a bit of an association with hereditary as well, is that there are certain genetic mutations which they be recognized as disease modifiers rather than the obvious cause for it. So there are certain genetic mutations in whom a patient will be more likely to develop chronic pancreatitis due to some other cause. So everybody who drinks a huge amount of alcohol is not getting chronic pancreatitis, is it? And on a similar note, they're not getting, say for example, cirrhosis either. So there must be something else which makes one person more prone to develop either one of these compared to other, although they might be drinking the same amount. So there are genetic mutations which makes one person more prone to pancreatitis from other causes than somebody who doesn't have that mutation. So a little bit of kind of introduction into what causes pancreatitis, chronic as well as acute. Anything you want to ask in this discussion? I think you know more of this. I just wanted to have a little bit of a recap and kind of highlight what are the major differences between the two. Now, what is very important is medical management or treatment by medication of various different problems associated with pancreatitis is very important, and that's why I was asking you, David. I think the last one, Dr. Nair had spoken about medical management, and so he actually helped me prepare this. So that was his talk last time. So I have actually not gone into medical management too much, because I think that's something which has been covered not so long ago.
That's right.
And but if there is any issues which we can talk about that. But what I have tried to do is to go into the surgical management, and I think I'll deal with the acute pancreatitis first. There are a few new developments which some of you may have kind of come across. So acute pancreatitis is one of the scans of a patient who has had acute pancreatitis. There's a lot of fluid collection around the pancreas. This is the left kidney of the patient. The important thing about acute pancreatitis and why medical management is important is that the patients who develop complication from acute pancreatitis gets complication elsewhere. It involves other organs, like it involves lungs. You get fluid around the lungs, you can get respiratory failure. Those who get complication ends up in ITU, ventilated, so it can become quite a serious illness. So the problem with acute pancreatitis is to identify those who are going to become serious or who has the potential to become a serious or what we call acute severe pancreatitis, because they affect the lung, they affect the heart, they have effects on the gut function, and quite commonly they affect the kidneys, so people develop renal failure. But fortunately, that's in a very small percentage of patients who get acute pancreatitis. So, 85% of patients who get acute pancreatitis get mild attack, which is very good. They get an attack of acute pancreatitis. There is usually an obvious cause, like gallstones, and it is self-limiting, it gets better on its own, and we identify that there is gallstone, we offer surgery to remove the gallbladder, and they will not get an attack of acute pancreatitis ever again. So it's a very straightforward problem, and fortunately that's what the majority is. In only 15% we get severe attacks. The volume is about roughly 200. It's a bit more now actually the last year, I think. About 200 per year in this region. There are two terms which is quite often used: predicted severe acute pancreatitis and severe acute pancreatitis. Now, predicted severe is a very important concept. Anybody who gets admitted under our care with a diagnosis of pancreatitis or acute pancreatitis, which is usually diagnosed on the basis of a blood test, gets a scoring done at the time of admission. Whether, if any one of you have got the experience of that or not, the scoring you don't get to see, but it is scoring done entirely on the basis of the blood results on admission. And that scoring tells us whether it is likely to be severe or likely to be mild. If it is a predicted severe, then they are treated with a bit more sort of invasive monitoring. We are a bit more careful, a bit more vigilant. We usually try and put them in a high dependency setting to make sure that we see how much fluid they're getting, how much urine they're producing, and we are very aggressive with them. Whereas the predicted mild can be kept in the ward, and as I said, they usually have the outcome like this, 85%. However, about 20% of the predicted severe actually become mild, which is again good news. So about 80% of the patients who are predicted severe will become severe. So this is not, the scoring system is not 100%, which is what I'm trying to say. All it tells us is that this person is likely to be more complex than the other who is predicted mild, and we can be a bit more vigilant. Whereas the severe ones are the ones who have got a complication of pancreatitis, and that's that 15%. So this 85% mild includes some who we thought would be severe, but were not. Okay? So severe acute pancreatitis is defined by presence of a complication, and I'll tell you what sort of complication. So you can get formation of abscesses, formation of pancreatic necrosis, or bits of pancreas not functioning, not viable, organ dysfunction like kidney failure, I mentioned, and formation of pseudocysts. This is a term which has probably been quite often used in the clinic when you come to the clinic, which basically means formation of fluid collection around the pancreas and not in the pancreas. So they're not really proper cysts, they're pseudocysts. But that's a recognized complication of acute pancreatitis and chronic pancreatitis as well. Just mentioned that there are a few of the criteria we use to try and predict who is going to be severe, who is going to be mild, and also these criteria are used to treat local, to sort of grade local complication and treat the patients accordingly. So in acute pancreatitis, just to summarize, we are quite keen in the beginning to predict whether this is going to be severe or not, because it's the severe acute pancreatitis which is the major problem and has got quite high mortality, risk of dying from the disease. So the other problem with acute pancreatitis is pancreatic necrosis. Now let's forget about the infected word for the moment. Pancreatic necrosis means is that as a consequence of acute pancreatitis, part of the pancreas doesn't get a good blood supply, and that is as a result of the acute inflammation, and basically the cells of that part which is not getting a good blood supply, with time they become non-viable or die or necrotic. And that does not necessarily mean that there's something dramatic is going to happen, but usually the body tries to repair this area by formation of lots of fluid around it. So that's actually not a normal scan, obviously. It's not, I'm saying obviously, it's not very obvious, but the thing is, this is kind of normal pancreas with a little bit of fluid around it, and here you can't actually see where the pancreas is. All this is inflammatory tissue and fluid. So this necrotic pancreas, or the part of the pancreas which is not viable, and the fluid surrounding it which our body generates, as long as there is no bugs in it, there is no infection in it, it's fine. Because with time our body will try to absorb this fluid and get it better. As long as we can support the nutrition, the body will correct this. But if it gets infected, then it's a problem. Now where can the bugs come from? They usually come in the bloodstream, and they just settle down there because there is a good place for it to have in a good culture medium basically. But if it does get infected, then you start developing lots of problems. And that infected pancreatic necrosis is the commonest cause of the organ failures that we see in acute pancreatitis. And here I have mentioned this, that surgical debridement, which basically means removing this infected necrotic tissue somehow, surgically, is absolutely essential. Otherwise, it is associated with a very high mortality. So this 80% risk of dying from this is if you do nothing. Okay, if it cannot be treated, if it cannot be drained surgically. Now that's rare now. This is sort of historical figure. But that's what was quoted before, is if somebody has an infected pancreatic necrosis and is not treated by surgery. So you can see that it has a very high risk of dying from it. So this is the situation where we must do something surgically in order to treat. So indication for surgery in acute pancreatitis is very important. When do we do operation in acute pancreatitis? So what I have said till now, that in majority of the cases it's mild, so they don't need an operation for the pancreatitis itself. They may need an operation to take away the cause of pancreatitis, like gallstones. The others who are predicted mild, some of them will get better and will not have any problem. Some of the predicted severes or the severes will develop local complications like abscesses or necrosis, and some of these necrotic pancreas will get infected. So all the patients who get pancreatic necrosis, only about 30-40% will get infections, others won't. Okay. So when are we going to do an operation in acute pancreatitis? Only with infected necrosis. So you can see that there is a very small percentage of patients with acute pancreatitis actually end up requiring an operation. We do see quite a lot of these patients in this hospital because they have been referred from all the other hospitals in the region. But if you look at the total number of patients who are having admission with acute pancreatitis, a very small percentage actually develop an infected necrosis and require surgery. And this is one of the scans which gives an idea about infected necrosis. If you remember the previous one, there were lots of inflammatory tissue, but there was no sort of black area like this, which usually indicates some gas in it, and that's an indication of infected necrosis. And if that happens, we almost always intervene. Okay? And if you look at present literature, that is the only indication for surgery in acute pancreatitis. The only other situation where we end up doing an operation in patients with acute pancreatitis is if there is a diagnostic problem, if we think this is something else. Okay. There are a few other, abdominal emergencies which can mimic pancreatitis. So it's only, this is that if we knew that it was pancreatitis, we probably wouldn't operate on that. Yeah. So this is the only indication. So in the past, what is the development that has happened? In the past, we used to always do an open operation with a huge big incision. There would be a big cut in the tummy. I don't know whether there is anybody in the audience here who are being operated in that, it was 5-10 years ago with a big incision. So you would know what I mean by the big incision. So the main problem with that, they did get better because you would remove the necrotic material, try to give a nice washout, get the healthy tissue exposed. But the problem was a presence of a large abdominal wound, and by stirring things up, in a simplistic term, by stirring things up, we would make the organ failure worse initially. They would get better afterwards, but the overall morbidity, overall complications were pretty high. And then over the last last 8 years, we have gradually moved away from doing an open operation and did what is known as a minimally invasive technique. This is, in this country, was started in Glasgow, and then we took over, and Glasgow and Newcastle probably has the maximum experience in doing the minimally invasive technique. And it's quite incredible that last 3 years we have not done an open necrosectomy. We have not done a single one, although the number of admissions have increased. So the rationale, obviously we can do it either as a definitive procedure in patients this is the way we started it. In patients whom we thought were too high risk surgically to have a big open operation, we went for doing a minimal procedure. And we used it as a bridging procedure to improve the patient's condition by taking away necrotic tissue and moving on to an open procedure. But nowadays that has changed. We don't do it anymore. We don't do an open operation anymore unless absolutely forced to. So it can be done either through what we call percutaneous necrosectomy, by putting a little needle and a drain and then doing the procedure. I'll show you a few pictures of it. Or by doing a laparoscopic procedure where we put in a camera into the abdominal cavity, just like doing gallbladder surgery. Again, not a very popular method anymore. And the other thing which we tend to do, and which I think Dr. Nair may have mentioned before, is by putting a camera through the stomach, or what we call endoscopic necrosectomy. This is the one which we commonly do, we surgeons do, same picture. So we put in a needle while doing a CT scan. This is that our X-ray doctors, the radiologists do it, and they put a little drain in there, and that's the drain placed in the same cavity shown by a plain X-ray, not by a CT scan. And we do a procedure to take away that necrotic dead tissue and place a big tube drain in it. And this path is used for clearing that necrotic cavity. The only problem with this procedure is that you have to repeat it. You can't remove the whole lot in one go. So every patient ends up having a few trips to theatre over a period of time. And that's perhaps the only sort of tedious bit of this procedure, and it's a bit frustrating for the patient because you have to be in hospital for a long time. But no surgical talk is complete without showing a few gory instruments. So I have to show that this is the instrument which is used for the procedure, and not all of them at the same time, but this tube actually goes inside the cavity in order to produce the trap through which we actually do the procedure. So we gradually, that drain which the X-ray doctors put out, we gradually increase the size of it by these metal beds, and then this blue sheath is put in, and this camera goes in through that in order to clear the area. Those of us who have seen him before, this is Jeremy, our colleague, who, just to show his picture. So that's the camera through that drain, and that's the sort of picture you get. You can see the blue color of the sheet because the camera goes in through there, and those are the dead bits of pancreas which you can see as soon as that tube goes in, and then they are kind of gradually removed from there. And no more gory bits. These are the bits of the dead pancreas which is removed. So that's what happened. The reason I showed it is it doesn't come up as one bit. It comes up as small bits, and that's why you have to repeat it, because you cannot remove the whole lot at the same time. The only other problem is kind of anatomical. If it is towards the right hand side of the pancreas, it's very difficult to get to it because you come in the way of lots of other vital structures. So by anatomically, the body and tail of the pancreas, which is kind of the left hand side of the pancreas, is easier to do it with this procedure. But for the head of the pancreas, it's a bit limited access, where the endoscopic method is much better. So as you can see here, the necrotic cavity with fluid is a bit more to the right, towards the liver, not towards the left of the patient. And there, this is, if I, you'll have to believe me when I say that this is the stomach. And if you put a camera into the stomach, it's very easy to access it from there, rather than from this side, which is a long distance. And I'll show you something else as well. You notice that we had put in that little drain from this side. This is the spleen. So if it is this far away, you can't put in a needle across all these structures. It's much easier to come from the stomach. So yeah, so there is a different strategy which we can use in order to drain the areas which are towards the right hand side of the patient. So that just put in a few points where it is difficult to do a percutaneous procedure, and we tend to do it through the camera. So that's as far as the development in this hospital and in general has happened for acute pancreatitis. Everybody has moved away from open necrosectomy and has gone for minimally invasive. The patients do a lot better in spite of the fact that they have more trips to theatre, because it's just like having a little cut, because once you are out of theatre, all you've got is that little drain and no incision. So it is that way the recovery is much better. We can maintain the nutrition much better. Problem with chronic pancreatitis, it's a bit different. It is not the acute phase that we are worried about. The patients have problems with pain. That's the main issue is pain. There are other things obviously, the deficiency of enzymes for which we give quinone as a supplement, deficiency of hormones, deficiency of insulin, so most patients become diabetic, not all, but most patients become diabetic, and it causes nutritional issues. This is a picture of chronic pancreatitis. As you can see, this is the pancreas gland, but you can see little specks of calcium or what we call pancreatic stones in it, more pancreatic stones in this bit. And these are all signs of chronic pancreatitis, chronic inflammation or chronic scarring of the pancreas. And they get acute bouts of pain, but almost always there's a background pain, and it's the pain which becomes a big issue which we need to treat. Let's just go through this quickly. It's just a, depending on where we come from, the cause of chronic pancreatitis and incidence are all very different. Here in the Western world, mainly alcohol related. Coming quickly to surgery for chronic pancreatitis. What is most important is that there is, again, the indication for surgery in chronic pancreatitis is pain control and nothing else. It doesn't improve the enzyme secretion, it doesn't improve diabetes. Sometimes it is used for treating complications like formations of fluid collection cirrhosis. Sometimes inflammation, chronic inflammation of the pancreas, which is just the first part of our small bowel is wrapped around it. This is the gallbladder with the bile duct. The inflammation can cause narrowing of the bowel, causing problem with eating. That may need surgical correction, or it can cause blockage of the bile duct, and patients can go jaundice, and that may need surgical correction. So you may need surgery for complications of chronic pancreatitis, but for pancreatitis itself, it is only for pain control. And these are the complications which I have already mentioned. Pseudoaneurysm means formation of abnormal swellings of blood vessels around the pancreas. This is one of them actually. And that can require interventions surgically to correct. Common procedure, surgical procedure for chronic pancreatitis is the drainage procedures that we do. The drainage procedure, by drainage procedure I mean drainage of the pancreatic duct. And I'll show you a few pictures to try and explain what it is. This is the pancreatic duct to the middle. This picture shows, this diagram shows as if the pancreatic duct has been opened up by an incision. And that's exactly what we do. The logic behind that is it releases the pressure inside the pancreatic duct and also tries to take away as much of abnormal tissue as possible. But again, just to emphasize, only pain control. That's what we're doing it for. There are different types of drainage procedures. There are quite a few. You probably have heard the name of a phrase procedure. Is there anybody here who has had that procedure? Phrase procedure. You have had the procedure here. There are lots of other procedures named after various different people. Any pancreatic surgeon who has done something has named a procedure after him. But what does that mean? That basically means that most of them are not effective. That's why you've got so many procedures. If you've got an inflammation in your appendix, there's only one way to remove it, and that always works. And that's why there's not 500 different ways of doing an appendectomy. The reason why there are so many procedures is that we always try to improve the outcome, which is pain control, and there is a definite failure rate. But phrase procedure over the years has become the most popular procedure because of the fact, number one, it's quite easy to do compared to all the other procedures, and secondly, the pain control or the pain-free period in phrase procedure is perhaps the best. There's another procedure which is also quite commonly done in Europe, in mainland Europe. It's a German surgeon who described this. Beger's procedure. It is very philosophical, it's very similar to phrase, but it's much more difficult to do. So we tend not to do that anymore. So we very rarely do it. If it is associated with a mass inflammatory mass in the head of pancreas, it is sometimes easier to do a Beger's than a phrase. When do we not do surgery? If pain is not a prominent symptom. If somebody who's got chronic pancreatitis with lots of problems with diabetes, lots of problems with nutrition, lots of problems with not having enough enzymes, but the pain control is not an issue, then you should not offer surgery ideally. Or obviously if the patient is unfit for surgery. If there is any blockage of veins around the pancreas which makes surgery a lot more risky and difficult. Any suspicion of cirrhosis of the liver, you should not operate. And if there is alcohol-related chronic pancreatitis and there is still significant alcohol consumption, the pain control is very poor after drainage procedures. So a few things about phrase procedure. We always try to plan it beforehand to look at the anatomy of the duct, because the operation depends on opening up the duct and presence of stones. So these are kind of a sort of surgical checklists to make sure we have looked at it. Again, a few pictures of what we do. This is a very favorite toy of ours. This is actually an ultrasound machine which can be directly used inside the abdomen. So this bit is completely sterile and it gets connected to an ultrasound machine. And we very, very frequently use it to locate the duct, because it is sometimes quite difficult to, even when you expose the pancreas, to figure out where the actual duct is because of the inflammation around it. And this actually gives us a very clear picture of where the duct is, and that needs to be opened up after that. It's very difficult to see this properly, but you remember the picture I showed where there was a C loop of the bowel wrapped around the head of pancreas. That's the loop of the bowel. So this bit is the head of pancreas, and that's not normal. It's just because of the inflammation. So it shows up as so much red and inflamed. That's the duct which we have opened. There is a couple of better pictures of it. And that's the open duct. So that's pancreatic tissue. And that's the main duct of the pancreas, which is open. These are stitches which are placed on the sides of the duct in order to keep it open. And that helps us to join up with the loop of bowel through which we drain it. So this is all the operative pictures. Okay. There are a few problematic ones in chronic pancreatitis, and the two are chronic pancreatitis in children and hereditary pancreatitis. The reason I said special cases is that the decision of when to operate is a bit difficult. Obviously, in children, the difficulty is you are doing a fairly large operation of the pancreas with a significant failure rate in pain control. And what is the failure rate of pain control? For phrase procedure, we quote up to about 15 to 20%. About 20% might not have any change in pain control. And then you're subjecting a young child to an operation where you cannot really predict how long the pain-free period is going to be. You can argue that you can do an operation here, which I think a few lectures before, I think Steve White gave a talk here about islet transplantation.
Yes.
That you can argue that you should take the whole pancreas out and do an islet autotransplantation. Now, the idea behind that is to take the islet cells which produces the insulin from the pancreas and put it back into the body, and it can be placed into the liver, which is I think what was shown in the talk. And that might be a good argument in children, because you've taken away the pancreas, which is causing the problem, and you have kept the function of the insulin. Same sort of a logic for hereditary pancreatitis. The reason we do an operation in hereditary pancreatitis is actually twofold. One is obviously pain control. It's no different from any other forms of chronic pancreatitis. But the other is that a higher risk of developing pancreatic cancer. So if that is why we are doing an operation, you can argue that you should do a total pancreatectomy or remove the whole pancreas and do an islet cell autotransplantation. The important thing in these both two cases is if we go down the route of removing the whole pancreas, we should actually do it early rather than when pain becomes a big issue. Because you want the islet cells to be good enough to work. And that's where the problem is, that how early is early? When should we actually do it? And total pancreatectomy actually, as an operation, carries a lot higher mortality than any one of the drainage procedures. So the role of total pancreatectomy itself is fairly limited, and patients who have had chronic pancreatitis for a long time will not benefit from doing anything with the islets. Okay? Only logic behind total pancreatectomy there would be to remove all scarred pancreas tissue, and there is no evidence that that produces better pain relief than a drainage procedure. The problem we face in chronic pancreatitis is that there is no tool by which one can predict who's going to get a good result. And that's the main problem. Just a few, as I was mentioning to you, about timing of pancreatic surgery is important. It is a serious operation, and we rarely do it as a primary surgery in chronic pancreatitis, but it needs to be early enough for the islet cells to be good enough.
Can I just ask you there, because we are funding as a group Steve White's current research, and as far as I understand it, one of the things that we're actually engaged in, that we had a talk about, is precisely these biochemical assays that may address the problem I think you've just mentioned.
That's right.
Is that right?
Yes. I mean, all the research are actually directed, not only here, everywhere directed towards that, is to try and predict optimum time where you should do it, where the islet cell volume will be good enough for it to work.
And the cell's still active enough.
That's right.
Yes.
Traditionally, if you see all chronic pancreatic patients, they're not all diabetics, isn't it?
No.
Not all of them are. Yeah, the risk of diabetes is higher in somebody who's got chronic pancreatitis compared to somebody who hasn't.
Yeah.
However, not all of them are. That basically means that the inflammation, it depends on where the inflammation is mainly, whether it is involving the islet cells more or whether it is involving the enzyme producing cells more.
Yeah.
And all the research are kind of directed towards finding that what predicts this. And if you know that, then you can select the patients who will benefit from this.
Right. And Steve White was getting quite optimistic.
Yes, I mean, I think there is actually there are two things, and I'll show you the next slide. The two things, one is to find a model of predicting the patients who will do well.
Yeah.
And I think there is a lot of good results coming out of that. The other thing is the insulin independence. After putting the islets in, how can we improve the insulin independence of the patient? If we can achieve that, then this operation is going to be great. Because we are doing, pancreas transplants all the time, isn't it? So this is obviously much simpler than that. But the overall complexity or overall morbidity is higher than a drainage procedure. But the idea behind the total pancreatectomy is that it is not only addressing the pain issue, it is also addressing one of the functional problems of this disease. Okay? So I think the future lies in trying to predict when we should do this operation, and also if we can keep the patient insulin free or as low level of insulin requirement as possible for as long as we can manage. Okay?
Thank you.
So I would like to conclude. Few things I would like to highlight here. One is very important, very limited role of surgery in pancreatitis, and it is very specific where you need surgery. So majority of the patients can get away without it. However much I like surgery, you guys should avoid surgery, if you can. And the main treatment of pancreatitis as a whole, if you look at the whole set of patients with acute or chronic, the main treatment is prevention. In acute pancreatitis, all we try to do is find out the cause and stop that so that it doesn't get another attack. And in acute pancreatitis, it's very easy because lots of it is gallstone related, or lots of it is alcohol related. So if the person stops drinking, won't get another attack of acute pancreatitis. If a person has got a bit of a confusion about whether the cause was alcohol or gallstones, and there is documented gallstones, we always take the gallbladder out because that definitely takes away one of the causes. Very important to understand that each patient is different and there is no straightforward answer to what will work best. So both the medical as well as the surgical treatment is kind of bespoke, and it has to be designed for that particular patient's problem. As you could see, that even where the location of the necrosis is determines what treatment we are going to do. So it will change from person to person. There's no one way of doing it. Timing of surgical intervention is very important, and this is more so kind of in acute pancreatitis rather than in chronic. And as you can now see, there's a lot of different people getting involved in it. The physicians like Dr. Nair, surgeons. There's a lot of involvement of the radiologists, the X-ray doctors these days, in order to help us with the minimally invasive procedures, and lots of involvement of the pain team, the anaesthetists who look after these patients in the ITU. There's a big team here now who are all quite keen on getting a good outcome. And the other thing which I find is very important, especially in chronic pancreatitis, is that failure to achieve symptom control or failure of surgery, especially in drainage procedure, for symptom control need to be discussed with the patient beforehand, which we sometimes kind of don't emphasize. And I think it is more a duty of the surgeon to discuss the failure rate and what are the possible causes of failure. One of the, I didn't go into details of it. I showed a patient who had lots of stones in the pancreatic duct. Those who have got a big duct, lots of stones, they actually do well when we drain it, because the cause of pain is thought to be obstructions caused by the duct, so they tend to get a good result. Whereas those who have got pancreatitis, chronic pancreatitis, very narrow duct, no stones, they tend to do badly pain control wise, because the cause of the pain is probably not due to stones and intraductal pressure. The cause is more due to the scarring and nerve involvement. So whatever you do drainage wise, they will not do very well pain control wise. You can argue that in that group maybe a total pancreatectomy is a good operation, but that we have never been able to prove. So avoid surgery if you can. That's the important thing. The problem is we have not been able to, because you have all been in outpatient at some point or the other. And there's a few questions if you want to clarify something. These are the guys who have helped me with this presentation. We all work together as a team. Thank you very much.
Thank you.
You want the question?
I have one, but I forgot it.
You forgot
There
it?
was needed to start.
Any answers will come back.
You didn't mention endoscopic procedures. Do they not count as surgical?
Yes, they are. They're interventions, obviously. Endoscopic procedures to drain the endoscopic version of the pancreatic necrosectomy, which I kind of sort of just touched on.
Yeah.
And Dr. Nair and the interventional, the gastroenterologists are very, very,
Right.
keen on it, and they do quite a lot. What we have now, because we work with the physicians as a team, yes, they are no different from the surgical drainage as far as the basic principle of the operation is concerned. The problem with endoscopic procedure which we find is that we can't drain them as well as we can drain it with the route from the side. So as a result, sometimes what we have done is we have combined it, we have done both. If you find a necrotic area which we can approach to some extent from the skin, and there's a bit which we can't get it, we have done both. The advantage of endoscopy procedure, however, is that it doesn't need a general anesthetic. So if you can find a way, and apparently there is a company which has come up with a device by which you can actually, let's put it this way, grab the necrotic bits much more effectively through an endoscope. And it is available in America apparently. So if we get that, maybe we will move more towards endoscopy, because there's a big advantage. It is not a general anesthetic. So all you're getting is a sedation, and just like a normal endoscopy procedure.
Thank you.
Anything else you want to?
Yes. Is there ways of testing for it? Say if I thought I actually had a pancreatic problem, could I go to the doctors and there's the tests that you could, or would you only find out when I'm in agony and pain?
Yes. I mean, most of the diagnosis is after at least one bout of symptoms.
Right. So you would have to have some sort of symptomatic problem.
Exactly. And as you mentioned, the commonest is pain.
Right.
Yes. Now, once anybody goes with an abdominal pain to a doctor, and especially if you go to an A&E department of any hospital with a pain which is as severe as that for you to go to an A&E,
Yeah.
you will get this blood amylase level checked.
Oh.
And that's a routine thing which is done everywhere. Now, if the amylase is high with somebody who's got abdominal pain, that is diagnostic of acute pancreatitis.
Right.
So it is very rare for us to be able to screen for pancreatitis, if you know what I'm trying to say.
Yeah,
But in somebody who has got, for example, the other extreme, has got hereditary chronic pancreatitis, by all means you can screen.
yes.
Okay. The two things you can do. One is functional test. So you can look for whether the pancreas is producing enough enzymes or not, and that you can do by a very simple stool test, fecal elastase. It's again an enzyme test. That will tell you whether there is enough enzyme being produced. And the second thing is whether they are diabetic or not. Okay, so this is the functional problem. And the diagnostic test in that case is a scan. Alright, so somebody who has got higher risk of developing pancreatitis because of the family history, yes, in them you can. But otherwise, the general population, there is hardly anything by which you can screen them.
Yeah.
Okay. But the good thing about it is that you would screen something which is a major health problem, isn't it?
Yeah.
Whereas luckily, 85% only gets a mild attack.
Oh.
So even if you get a bout of pancreatitis, there is an 85% chance that you will just have a mild attack and you will get better very quickly.
Right.
So that's, that's good.
Yes, of course.
Yes?
No, thank you.
Yeah. Okay.
Case in the paper yesterday,
Mhm.
if you're aware, the lady had a local procedure
Mhm.
by keyhole.
Mhm.
But there isn't much research into that.
Right. So keyhole procedures are obviously we are keen on keyhole procedure for everything. Yeah. The advantage being it is quicker recovery. Even if we completely ignore the scar side of things, the faster recovery is a major thing for keyhole procedures. We have always been a bit concerned about doing keyhole procedures for cancer. Okay. We always felt that we will not get as much clearance of tissue by keyhole as we would do through an open operation. But there has been lots of trials on bowel cancer, for bowel cancer surgery, and it has shown no difference whether you do it through the keyhole or open. So the majority of the bowel cancer operations nowadays in this country are through keyhole. Whipples by itself for pancreatic cancer is technically quite a difficult procedure. And so that's why we were very reluctant to go down that route. But lots of centers have shown, we haven't done keyhole whipples here as yet. Lots of centers have shown that it can be done safely. But what has been the experience throughout, those centers where they do whipples through keyhole is that their long-term survival is no different. So an operation which takes about 6-7 hours to do, you're increasing it to about 12, 13, 14 hours by doing it through the keyhole with the same outcome and no major change in return to work. The reason for that in whipples has been that the main problem we get in whipples procedure is not because of the wound, it's because of problems with the anastomosis leaking and things like that, the joint up leaking, and that's no different whether you do it through the keyhole or not. So if it can be done through the keyhole, there is no reason why we shouldn't. But there is not a major difference in outcome. Whereas in bowel surgery, there is difference in outcome, definitely. In liver resection, which is the other thing which we do liver surgery for tumor. We have gone quite a bit towards keyhole now. Because again, there's a major difference because you don't have a huge big incision. And if somebody is having a bowel operation through the keyhole, gets a tumor spread to liver, it would make sense to do the liver operation through the keyhole as well. So yes, technically there is no reason why it cannot be done. I think Leeds, there is a consultant who's quite keen on doing it. Manchester,
It's just done in London.
yeah, in London also. Yeah. So yeah, it is in the Far East, in Japan and all, it is quite common. But I mean, it is, I think the patients are a bit thinner as well, and it is, I think they have got quite an active screening program for pancreatic and gastric cancers, so they get patients early as well.
Even though it's at the average, the normal age for people who get found out to have pancreatitis is between 40 and 50, is that the average age for people on surgery?
A little bit more than that for average for people having surgery. So those who get diagnosed with pancreatitis at sort of average age of 40 to 50 would not immediately go on to have operation. But if you look at it, it's not a major difference, because when we diagnose patients with pancreatitis, it's very difficult to say for how long they have had it for. So most of the time we diagnose patients who are having pain of some sort. So they get to surgery after about a few years. So not a huge big difference. Yeah, is that clear? Excellent.
Anyone else?
Good. Excellent. Right, thanks very much, Francis.
Well, I must thank you for that. A very thorough, not to say reassuring, talk, because if I'm to speak personally, I've got the big one.
Yeah, you got the big one. I know you got the big one.
And it saved my life, quite clearly. But I was interested in levels of morbidity and mortality. I mean, when I had that operation, which is now 8.5 years ago, and I gather it wouldn't be done now, probably. Something else. But when, I at the time recognised that I had nil chance if I didn't have anything done. And was told something like, well, 60-40 if we go ahead. And I managed to say to myself, I'll grab 40 or 60, which is better than nothing. But I imagine that from what you said tonight, that those kinds of levels have been reduced
Yes.
enormously, partly by not doing so much open surgery.
Yes.
And partly, yes, by better timing and all
Yes.
sorts.
I think
Is that right?
the better timing is more the issue.
Yeah.
And we have over the years, I mean that has been the research as well, people have recognized is that, that's why I was trying to highlight is that it's only a very small percentage of people who actually needs a surgical intervention.
Yeah.
If you don't get infection, majority of the patients will actually get over it.
Yeah.
If you can support nutrition, which is the other thing which has improved over the years.
Of course.
So yes, if you can time the operation well and do it in a way that is the least
Yes.
stress or trauma to the patient,
Yes.
you would get a better result.
Yes. Well, I'm sure that's right. I'm just grateful that it was in time.
Yeah.
Because I was thinking fast. Look, I'll get away from my own problems, which are no longer problems, thanks to this lovely hospital. But thank you, Gourab, for a very clear and, as I just said, comprehensive talk tonight. You have a winning way of making very complicated things look as if we can understand them as laymen. And I'm very grateful to you for that. I'm sure we all are, and I think we should thank you in the usual way. I think we could go back and have another. I've got to draw a raffle, don't we?